Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hello, everyone. Welcome back to the Breast Cancer Podcast. I'm Deepa Halaharvi, the host of the Breast Cancer Podcast. And today I'm really excited to have Dr. Lucy Bucher. She is an OBGYN and also an associate vice president of clinical affairs at Ohio Health. And so I am very excited to have you here on the podcast. It's on YouTube as well as the audio version on the Breast Cancer Podcast. And we spoke to each other about 3 years ago during COVID virtually. I was doing some virtual series for our audience at that time through Ohio Health. And you had wealth of knowledge. And I am so excited you're back, Dr. Bucher. And I cannot wait to hear all you have to tell us, and June being Pride Month, and I thought this would be a great time to talk about our LGBTQ population as well as the impact of breast cancer. And so I wanted to start there, and I wanted to, take some time to introduce yourself and go ahead if you want to tell our audience what you do.
Yeah, thank you so much for having me. I'm really excited to be here. I'm an OBGYN by training. I practice clinically still. Over the past several years, I have started to hone a portion of my practice towards caring for gender diverse populations and providing gender affirming care, as well as I like to think that I am a safe space for people who've maybe had a rough time in the OBGYN space as patients before. And then for my administrative role, I help work with our hospital and our health system to make sure that clinical care is the best it can be throughout the system, providing resources, breaking down barriers for our providers to be able to provide care for our communities.
That's wonderful. I'm so glad you work here in Ohio, and you predominantly work in Athens region, correct? Or
I
do you go
do.
to
Yep.
other locations?
Nope. My clinical practice and my administrative role is centered in Southeast Ohio and Athens, Ohio.
Okay, awesome. Well, we are so glad you're here in Ohio, and I hear nothing but great things about you. We do share some mutual patients. So I'm really excited that you're here. And I would really wanted to talk about breast cancer awareness in the LGBTQ population because when we say breast cancer, we think of pink washings, right? October,
Yeah.
it's Pinktober almost. And that's really, in my mind, as geared towards majority of the breast cancer survivors who are heterosexual, who are predominantly white, because there's a lot of breast cancer that happens in African American population, South Asian community, which is very different type of breast cancer than we see in the Caucasian population. And we really don't talk about the impact of breast cancer in the LGBTQ population. And so, you know, they do feel excluded from, talking about breast cancer awareness and what things that they can do to help themselves. Do you agree with that?
I do. I think for any underrepresented minority, whether it's based on race, ethnicity, gender, sexual orientation, if you don't see yourselves represented in the media that's out there, the advocacy that's out there, it doesn't feel like it belongs to you. But what we know is that um, people who are LGBTQ, gender diverse women are affected by breast cancer. And some of those metrics are starkly different from how it affects cisgender heterosexual women.
Yeah, 100%. And we know American Cancer Society talks about over 1 million LGBTQ survivors, cancer survivors in our country. And they're, and we people think the risk of cancer, the incidence of cancer is increased because of their sexual orientation. That's actually not the case. The reason that there is increased incidence is because of they have the same risk factors as heterosexual men and women. It's just that there's more prevalence of cigarette smoking, alcohol use, maybe obesity, and maybe women putting off having children, or cisgender putting off having children. So I believe those are some of the risk factors that are quoted as the causes of increased incidence of breast cancer. And do you agree with that?
Yeah, so there was a really fascinating paper. It was small in power in terms of like the study size. It came out last year, and I don't know if you've seen it from Stanford, but it
Have,
compared like
yeah,
92 LGBTQ breast cancer survivors with 92 cisgender heterosexual breast
yeah.
cancer
It's
survivors.
Dr.
Yes,
Eric Erickson, I want to say is his name.
Eric Earhart. Eric,
Eric Hart. Yeah, I just
yeah.
heard him on the podcast. He was on the Breast Cancer Org podcast talking about that paper, and I found that to be extremely fascinating. But I want you to tell our audience about that paper. Yes.
Yeah. So it was fascinating because when they compared people, there was a slightly increased use of alcohol and cigarette smoking and cannabis use. Um, and there was a like less, what was I going to say? Like LGBTQ breast cancer survivors had less children overall, and that was statistically significant. But when they looked at some of the other hormonal impacts that we know are predictive risk factors, things like oral contraceptive use, those sorts of things, time of menarche, which means when did you get your first
Yes.
period, those sorts of things weren't different between the two groups. But what they saw was that the time of diagnosis was nearly double for the patients who were in the LGBTQ population, meaning that they had about 64 days from time to diagnosis instead of 34 days. And then they had a higher risk of recurrence. So I think we need to understand what are the systemic and societal factors that are impacting how those patients are interacting with our medical system to understand what's driving that, because it doesn't seem like it's based solely on hormonal factors, given that they had a lot of similarities between the groups from those risk factor perspectives.
Yeah. I did see that in that paper, and he talks about that in that podcast. And do you think that has to do with the experiences this population have had with the providers, with the medical providers, whether it's fear of discrimination or they've treated poorly in the past, rates of lower health insurance, limited financial access? What do you think is attributing to that, to increased like time to diagnosis and also risk of recurrence? Like, what do you think is the factors?
Yeah, I would say yes. And I think we
Yeah.
don't have a lot of SOGI, so sexual orientation and gender identity information gathered in some of our really large population studies. Only a minority of studies gather some of that
Yeah.
information. So when we're looking at cancer overall, we don't have the data to break those out. So I think that we need to start doing that. And then we do know from studies where they have talked to people, asked questions of um, folks in the LGBTQ community about their experiences with healthcare, that a large portion of them do report feeling discriminated against, feeling, and then also making decisions to put off getting healthcare because of past experiences. We know that this population is at a higher risk of living in poverty, having housing insecurity, having intimate partner violence in their past. And all of those things are going to, especially for care that is centered around um, what would be the heteronormative gender organs, right? So
Yes.
things like pap smears, breast cancer screening, those sorts of stuff are going to be they're less likely to seek out that care proactively until there is a problem. And I believe I did see a study that showed cisgender heterosexual women were more likely to have, well, maybe I'm saying that backwards. So LGBTQ women were more likely to have a mammogram because of a symptom. So they felt a lump or they had
Mhm.
something that was found instead of just having a screening mammogram, meaning that they were just getting it because it was time for their annual mammogram.
Yeah.
Um,
Yeah. So I think since you're talking about the symptom, I think it's good to talk about that here. One of the things in my own research, this podcast is amazing because we are providing this information to our audience. Most of them are breast cancer survivors, some of them are not. But as a surgeon, as a breast cancer surgeon, I learn something every time I do this podcast, and that's why I love doing this. Is we often refer to as a breast exam, right? Instead of
mhm,
saying chest exam, because some of this population may not want to hear a breast exam. They may not feel
correct.
comfortable. Do you agree with that?
Yeah. So the word breast is not, it can be cause of dysphoria for some folks. So
Yeah.
they prefer the term chest.
Yes.
So a chest exam. But I think even then for trans masculine patients who've maybe had top surgery, so they've had either a breast reduction or a uh, they've
Mastect.
either yeah, a mastectomy or a breast reduction, they may still have breast tissue, which could develop cancer. So paying attention to those areas that where they did have surgery for any changes, lumps, bumps, those sorts of things are important too. They're not immune from it.
Yeah, yeah. So typically we say, any type of lump, hard knot, or thickening around the chest wall region, swelling, is nipple discharge, or puckering in the skin, or inflammation or swelling underneath the arm or lymph nodes. Pain, we say pain is not associated with breast cancer 95% of the time, but 5% of the time I do see women,
Hmm.
cisgender women come in with pain. So not to put that off. And thank you for bringing up the transgender men who may or may not have had chest wall surgery, either top surgery or reduction or some sort of surgery. If they have not had any type of surgery, they follow the same cisgender guidelines of getting an annual mammography at age 40. Unless they have family history, they've had chest wall radiation, then they do fall into higher risk and they may need to get mammograms and perform the chest wall exams much earlier than that age. And so, but cis trans men who've had surgery, they still need to be followed, whether with an exam, a mammogram, depending on how much breast tissue they have left. So that's really a great point that you brought that up.
Yeah, and maybe you can speak to this. The type of mastectomy that's done when somebody's having gender affirming surgery is going to be different from the type of
Yes.
mastectomy they would have done for a previous cancer
Yes,
surgery.
that is correct. Yeah. It's very different from having a double mastectomy where we remove 90 to 95% of the breast tissue. We typically do perform that for patients who've had breast cancer, whether they need the surgery or they want to have a double mastectomy. A top surgery is different in a sense, not all breast tissue is removed because they still want to have that chest tissue on the chest wall. And so, the surgeons, most of the time, it's performed by plastic surgeons. I've performed it a couple of times. I performed a double mastectomy number of times in LGBTQ population when they requested that surgery or they have, developed cancer, whatnot. I actually have a lot of my patients do fall into the LGBTQ population. So I'm happy that I feel like they trust me. They feel comfortable with me. But, this idea of doing this podcast just to promote more awareness amongst, that population. But going back to the transgender men who've had top surgery still need to be followed, whether with a mammogram and an exam or both.
Yeah. And I think it's important. One thing I stress when I talk about general, um, OBGYN care and, I'm going to say women's, but like women's health, all encompassing is that recommendations are recommendations and they're generally built for the average risk population. And so trying to understand who's giving the recommendation, because we know until recently, the United States Preventative Services Task Force varied in their mammography recommendations from some of the other groups of professionals. And then you might have specific individual risk factors that put you into that higher category. So it's important for people to talk with their physicians or their care providers so they understand, do they qualify do they need something earlier than 40? Or what does that look like for them?
Yeah, I think talking to the healthcare providers is really important. And I was born in India. In Indian communities, the people don't talk about family histories, right? This happens in a lot of ethnic families that they don't talk about family history.
Right?
And what's shocking, but not shocking really, LGBTQ, sometimes they don't even talk, they're not even talking to their families, right? Because the families may not be happy with their choice of their sexual orientation, whatnot. So they may not even be close to their families. So sometimes they don't know their family history, which, something that we as providers have to take that into account.
Yeah.
And so we talked about transgender men and transgender women. What are some things that you would recommend differently for transgender women? And
Yeah. Oh, go ahead.
so this population maybe is on hormones, right?
Right. So for transgender women, if they're on feminizing hormones like estrogen, some form of estrogen, they will develop breast tissue. They do have higher risks of breast cancer, higher incidence of breast cancer than cisgender men. And so it is recommended that they get mammography. There's not firm recommendations. I think most of what I've seen is if they've been on hormones for more than 5 years and they're over age
Yeah.
50, that it's recommended to have annual mammography. And they do tend to have dense or extremely dense breast
Yeah.
tissue, which we know is a risk factor.
Yeah.
I think, and you can correct me if I'm wrong because you're the specialist here. I think it's a risk factor for two reasons. It's a risk factor in and of itself, but also because it makes imaging more difficult to
Yes,
find.
yes. You're 100% correct. Dense breast tissue is white on a mammogram, and cancer is white on a mammogram. So sometimes the cancer can hide in the dense breast tissue. So it's difficult to find cancer. And the second fold thing is dense breast by itself is a twofold increased risk of developing breast cancer. So there's two reasons why someone could develop breast cancer is it could hide or it could also increase the risk of developing breast cancer. So yes, so for this transgender women who are on hormones, the breasts do tend to get to be a little bit more dense. And I see that in cisgender women as well who are on hormone replacement therapy. Their
Mhm.
breasts don't become, as we get older, our breasts become more fatty. When we're younger, our breasts tend to be more dense. And so with the hormones, women, and I can always look at an image, if she's a 65-year-old woman, I can almost always tell, okay, maybe she's taking hormone replacement therapy. Then I look at their medication list and, they are. So yeah, the medications can cause density in the developed density in the breast. And also transgender women, if we were talking earlier for transgender men, same thing. If you have family history, if you've had chest wall radiation, you're considered higher risk, then you would follow different guidelines and you would get mammography way earlier than age 50.
Yeah, exactly. And then maybe you can speak to if they've had breast implants or some other augmentation in addition to taking hormones that can impact their imaging as well.
Yeah. So in addition to taking, yeah, so that's a great question. In addition to taking the hormones, which causes breast density, and now they have implants. The one good thing about implants, depending on where they're placed, if they're placed behind the pectoralis, subpectoral, it actually pushes out the breast tissue. So it's actually kind of easier to examine the
Oh,
breast. So it's kind of nice. But, they probably need an MRI in addition to a mammogram as well, because now that they have implants and or on hormone replacement therapy. And for sure, if they have family history, they would definitely qualify for an MRI.
absolutely.
At our institution, we also have abbreviated MRI, which is very different than a traditional MRI. It's more for the average risk to intermediate risk patients, meaning you don't have family history, but you have dense breast tissue. So one could get an abbreviated MRI, and they can ask our providers for that, for the abbreviated MRI. And it's not very expensive, and insurance companies should pay for that.
One thing I've seen over the time I've been practicing is that there's more and more willingness by the insurance companies to
Yeah.
pay for additional imaging or imaging outside of just routine mammography for folks. So,
Yeah, yeah, there's a dense breast law which has really helped in Ohio. The insurance companies do pay for additional screening or additional abbreviated MRI or even traditional MRI if if they fall into that greater than 20% likelihood of developing breast cancer. So the insurance definitely pays for those patients. I also, before we leave this topic, I also want to talk about lesbian, gay, bisexual women who are cisgender. They still follow the cisgender guidelines, which
mhm.
for average risk women, they start mammography at age 40. If they have family history, they would be probably sooner than age 40. But I wanted to make sure we mentioned that before we move on to the other topics. Um, what are some ways to remove barriers to screening in this population?
I mean, I think education and just talking about it, things like this
Yeah,
podcast, so people feel like they have a voice, feel a little bit more empowered that they can go and talk to their provider. And I always encourage patients, like, if you don't feel like you can ask questions or you're getting sort of dismissed, like, find somebody new, ask around.
yeah,
I can't, we're all human, and
yeah,
not everybody, as my kids would say, vibes with everyone else,
yeah.
right?
No,
Like,
100%.
but
Yes.
but find your person that you can feel comfortable with. It shouldn't feel like, you shouldn't be feeling like you're burdensome
Yeah,
by asking more questions about what's next, or is that, what other options are there, or what, I'm not comfortable with that. Is there something else? Like, you should be able to have that conversation with your
yeah,
provider.
yeah.
Um, and then, you know, like, where I live and practice, we're in a relatively resource, desolate might be a strong word, but we are in a resource poor area of the state. Athens is the biggest city, sort of in this quadrant of the state. But we have a lot of people where there's no hospital and very limited primary care in their whole county. Transportation, resources, insurance coverage, those sorts of things, just getting to the physician. And they may not know that there are programs that provide free mammography, free pap smears, those kinds of stuff for the community. So trying to engage in that and understand what those resources are. Your local um, job and family services or community health programs often
Mhm.
have a line of sight into that. But I know here we do have a free breast and cervical cancer screening program.
Yes.
If you're uninsured, that you can get those things done on a regular basis as you need them, even if you don't have insurance, even if you don't have a regular primary care person. So
Yeah. No, that's a great. Yeah, the BCCP program is really great. And people need to be advocating them for themselves. I think that's the take home message from this podcast today is, and I will say, and I don't know about you, I didn't really get a lot of education about impact of healthcare in LGBTQ population. Did you when you went to medical school? Uh,
no.
yeah. And so a lot of this we like, find read on by ourselves on our own time and want to be educating ourselves so we can provide the best care possible without, we just want to decrease the disparities. We want to treat everyone the same, whether they are black, blue, white, yellow, regardless of gender, sexual orientation. We don't care. We just want to treat everyone the same. And platforms such as this is great to go listen to for people to get more information. But you're absolutely right. There are so many programs. I think people just need to talk to the providers, talk to other healthcare workers. There's plenty of people who are educated who want to help and help remove financial burdens. And also, if there's a cultural barrier, tell the healthcare provider. And we want to be knowledgeable, we want to be respectful, we want to provide a safe, judgment free zone for for this population, and that's our goal. And find someone like Dr. Bucher, find someone like me, find someone who will listen, and find that person until you connect, you vibe with that provider. I think that's really great. So um
Yeah, I think I would say, like, it, it's hard, like, in addition to taking care of yourself, a lot of times these things are on top of taking care of the other members of your family, whether it's your biological or chosen family. And so trying to prioritize that you need care too, and
yeah,
seeking care before there's something that's worrying you, right? Like, that's why it's called preventative care. That's why
yeah,
it's a
yeah,
screening. Those things are in place. And I meet plenty of patients who are like, "Oh, I don't really want a colonoscopy." And I'm like,
yeah,
"But you only need one very rarely, but it's because it catches things before they're a problem." Same with mammography, right?
yeah, yeah,
So it's an inconvenience in your busy day to day,
yeah,
but um, yeah, finding those places where you can get that done, and um, you know, I think is
yeah.
really important.
No,
Well,
exactly, exactly. And I will say, as a breast cancer surgeon who reviews a lot of literature and research articles, we don't have enough people that participate in research trials. And, there's not too many studies looking at the LGBTQ population with the medications. And speaking of medications, for the patients who get diagnosed with hormone receptor positive breast cancer, they have to take anti-estrogen medication for 5 to 10 years. That can be burdensome, that can have side effects. If this is someone who was already on estrogen, I know
Hmm.
women, like, so now you're stopping the estrogen. It requires a lot of conversation. There's so many things we can do for the side effects. And so just again, going and talking to your provider and what they can do to help you while you're on this anti-estrogen medication. So, and
Yeah.
enrolling in trials and studies, I think is so important.
Yeah, and I think that's the big people don't understand. Cancer care is really nuanced. And I mean, I am not an oncologist. I am not, but from what I know, yes, there are best practices and generalizations, but there are so many options and nuances for sort of managing or alternatives that maybe are helpful, but just they're not like the top of the list. And, if you can't tolerate that medication. So being transparent about how it's going for you and having somebody that you can talk to about like, hey, this really isn't working out. Is there something else I can do or something I can do to help mitigate the side effects, those sorts of things. So,
Yeah, 100%. And I think, like with anything, we want to empower ourselves, educate ourselves on all these screenings because what is it? Prevention is an ounce of cure or something like that. Like it's so easy to prevent. And, like in Asian community, there's a lot of heart disease. Like my mom actually has heart disease right now. I'm taking care of her in my home. But, she is a super tiny woman. So, so you don't think like, the super tiny woman could develop heart disease. You always thinking heart disease, someone who is like obese and have
hmm.
cholesterol. She is diabetic, of course, so that is, her thing. But she wasn't educated enough, and and she wasn't telling me everything that was going on in her life by living by herself. And so, I think it's important to educate yourself about these preventative services that are available for free of cost. Almost insurance should pay for it, and until if insurance doesn't pay for it, talk to people and participate in trials. And once you have the knowledge, I think it's important that we talk to our family members, important we talk to our partners, and help them get to the doctors, and the providers. So
Yeah, absolutely.
yeah, yeah. And anything else you want to say, Dr. Booker, about anything we talked about? Any other tips, pearls for our audience?
I mean, the biggest takeaway, whether I'm talking about this or something else, like I said before, is do your best to try and
Yeah,
find somebody who will sit and listen with you and help you really understand what the pros and cons are. Because we know the LGBTQ community is at a higher risk for not seeking, preventative care. They have a history of poor experiences with the healthcare system. Anything that we can do, and if you have any other providers listening to this, talk to your office staff, talk to your wherever you work, and talk about how can we make our place more welcoming and inclusive so people feel comfortable coming in. Because, like you said, none of us went into medicine
yeah,
to like we all went into medicine to help people.
right,
Nobody
right,
is here to like try and exclude
yeah,
people. And then I think additionally knowing what's in your community. So I have an awareness of what the community health programs are and who are the providers at my local Planned Parenthood or other places that provide free care, and how do we make sure that we're working together and what's available where. If it's something that you can't provide, where can they get that. And then the second thing is the education piece. Like you said, you
yeah,
didn't have a ton of LGBTQ affirming education. Neither did I. I know some of that is starting to change.
yeah,
Really proud of our local family practice residents. They've started what they're calling a Q clinic, and it's like a couple times a month where they're doing an LGBTQ clinic for primary care, right? So everything, whether it's hormone therapy or prep therapy and all kinds. And so that was really sort of resident driven, and I'm so proud of them for really kind of being a voice and saying, hey, this is something we need to learn.
yeah.
So for people who might be listening who are in the process of their education, right, understanding how they can promote that and they have a voice.
Yeah, no, that's amazing. That's great. Yeah. And not just prevention, but also if you're diagnosed with cancer. I will say about breast cancer, since what that's all I do is breast cancer most often is diagnosed early stage, and it's good survival, good prognosis, as long as it gets diagnosed in early stage.
Hmm.
And that's the important take home message from this. So it doesn't matter what your gender, sexuality is, be your own, empower yourself, get educated, get screening mammographies. If there is cancer, it's treatable. Most common cause of death is heart disease in America. That's like is as long as you're taking care of the breast cancer, the most common cause of death is heart disease. So we still need to exercise. Half an hour a day, 5 days a week, eating a healthy diet. Cut down on the processed food and processed meat and things like that. Cut down on alcohol because it's really nothing. It's empty calories, right? And
Yeah.
it's okay to occasionally indulge in it with celebrating, things like that, which I do too. But not to make it a habit to have a glass of wine every day. I think it gets to be too much. It gets adds up. And smoking is another big thing that we need to be mindful not to smoke. And marijuana, and I know it's legal in our state now, and I don't know what to think of that. I don't know if it's better than nicotine. I don't know. I feel like it's not, but I don't know. I don't know if you have any studies to show that.
I don't know of any studies. I don't know that we have any good longitudinal studies
Yeah, yeah,
because I think there hasn't been the funding and the access over
yeah.
time to see how is that impactful to people over their lifetime. So it
Right,
will be
right.
interesting to understand. And in places where it is legal, there's a lot less smoking of it, I think,
Yeah,
than other ways of getting THC too. So how
yeah.
does that change the risk
Right, like the
factor?
gummies, like we talk about that, like, how does that impact on someone?
Right.
But if you have to depend on some outside substances, I think, that's may not be a good thing. It's kind of how I look at it. Like, I have been taking care of my mom for 4 months. I moved her into my home. For mental health, I was very proactive. So I just go for walks now, which in the past I used to think walks is a waste of time. I should be running. I should be getting ready for a marathon. Otherwise, but I have found for my own self walking, and I don't do it as much on weekdays, but on weekends I try to do walk for an hour each day. It has been really change. It's changed my life. I was telling my husband, my mood is so much better. I can do so many more things and have more energy, and it has really been a game changer. And it's simple as walking, and we sometimes underestimate the power of walking. And anyone can do it. If you can't do it half an hour a day, maybe 10 minutes. Break it down to 3 times a day. So,
Yeah.
and eating a healthy diet, which means you have to plan your meals. You have to meal prep for the week if you're busy during the week. So that's something that I do also. And then if you're diagnosed with cancer, make sure you're in a survivorship program who's following you for, risk of recurrence, because, if there is recurrence, we want to find it again earlier so we can treat it. And then follow up after cancer too. It's important that they stay connected with the providers and clinicians. And I will say, I really admire you, Dr. Bucher, like what you do and your passion and your knowledge, and how you want to treat everyone the same. And we as clinicians and providers and physicians, we need to do better. We need to be educated. And I'm talking about the people out in the community who's not taking time to learn about these disparities. We need to decrease these disparities. It's not okay to treat people differently. And so I really admire you, adore you, and I just want more people to be like you, and help
Oh,
everyone. I just want to help everyone at the same, regardless of where they come from. So
oh, you're so sweet. Thank you so much. And I relish having you as a resource and a colleague. And I send
yeah.
patients to you and I say, trust me, you're going to love her.
Oh, thank you so
You
much.
know,
I appreciate that.
yeah.
Thank you. Thank you.
Um, so it's good to have those good connections. And
Yeah,
yeah,
absolutely. Absolutely. Well, thank you so much for being here today and for your time. And for our audience, this has been a great episode. It's going to help you, get yourself knowledgeable about the breast cancer disparities and all the negative impact you've had in the past. But now it's time to empower yourself and time to find a provider who listen to you and try to make you number one so you can take care of your family and friends. So thank you so much. You all have a good day. Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.